Close to 1 million people worldwide die by suicide each year. In the United States, suicide is the 10th leading cause of death across all ages, and it is the second leading cause of death among 18 to 25-year-olds. In India, it is estimated that 170,000 people will die by suicide each year, which means close to 20% of the world's suicides occur in India. In this video, I will introduce clinicians to factors that contribute to suicidal behavior, as well as review culturally informed and empirically based suicide risk assessments. Finally, I will touch on empirically supported interventions. First, let's talk about the goals of suicide risk assessment. Broadly, suicide risk assessments are formalized procedures to assess signs and symptoms of current and more long-standing risk, and the goal is to establish the client's current risk so that appropriate clinical actions can be taken. There are several well-validated suicide risk assessments, including Jobs's Collaborative Assessment and Management of Suicidality, Shea's Chronological Assessment of Suicidal Events, and Linehan's University of Washington Risk Assessment Protocol. Today, I will review the Suicide Risk Decision Tree developed by Thomas Joiner and colleagues. It should be noted that many clinicians are often reluctant to assess for suicide. This reluctance can stem from multiple sources, including taboos about suicide, feeling like one does not have the proper training to assess and deal with suicidality should it be endorsed, believing that talking about suicide may prime or prompt an individual into thinking more about suicide. However, research conclusively finds that assessing for suicide does not increase suicidality, and in fact, when assessment is done warmly, competently, and with the appropriate amount of rationale provision, it can increase rapport and lead to better clinical outcomes. Joiner's assessment model, based on the interpersonal theory of suicide, is a semi-structured interview that results in an individual being classified into one of four risk categories: low, moderate, severe, and extreme. This assessment was designed and developed for the outpatient use in the United States. It should be noted that these categories are flexible and individuals can fall in between categories, for example, low moderate or moderate severe. Although Joiner's model incorporates many standard elements, there are some novel aspects, including the emphasis placed on multiple attempter status, perceived burdensomeness, thwarted belongingness, and the capability for suicide. The assessment starts out by determining the nature of current suicidal symptoms and the specific nature of any previous suicidal behavior. When assessing for previous suicidal behavior, this assessment focuses on determining how many previous attempts there have been and the timing of these attempts. This emphasis stems from research which finds that individuals who are multiple attempters, in other words, have attempted 2 or more times, are at greater risk for a future attempt than are single attempters. Further, although a previous attempt elevates risk throughout the entire lifetime, previous attempters are most at risk approximately 6 months to 2 years after their last attempt. The assessment then moves on to determine whether the client has resolved plans and preparations for a suicide attempt. This includes questions about past and current suicide plans, preparations made for an attempt, access to means, and intent to act on one's suicide plans. Additionally, there is an assessment of other significant risk factors, which include perceived burdensomeness, thwarted belongingness, and the capability for suicide. The assessment also incorporates empirically based risk factors such as non-suicidal self-injury, hopelessness, precipitating and current stressors, psychopathology, impulsivity, and acute risk factors for suicide. These acute risk factors include agitation, irritability, social withdrawal, severe weight loss, and sleep disturbances like insomnia, nightmares, nighttime panic attacks. After conducting the assessment, the clinician should have enough information to assign the patient to a risk category. The assessment includes suggested actions for each associated risk category. Once the risk assessment is concluded, the clinician should make sure to document the assessment. According to the Joiner model, part of the management of suicidality includes routine assessment. Thus, it is recommended that clinicians check in with patients above low risk about any increases in suicidality at the beginning of each session. For low-risk patients, clinicians may wish to check in about changes in suicidality on a biweekly or monthly basis. Next, let's consider elements of culturally competent risk assessment. Chu and colleagues developed a measure to assist with conducting culturally informed suicide risk assessment. This measure is based on Chu's cultural model of suicide and includes 39 items that assess social discord, minority stress, idioms of distress, and cultural sanctions about suicide. Social discord includes family conflict and lack of extended social networks. In India, social discord can also result from pressures to conform to social norms or unsuccessful intercaste or interreligious romantic relationships. Minority stress refers to stresses individuals from minority groups in a given culture experience because of their social identity or position, and includes discrimination, maltreatment, harassment, and internalization of stereotypes. Idioms of distress acknowledges that the nature, expression, and behaviors of suicide are influenced by one's culture and identity. For instance, in the United States, ethnic minorities are less likely to report suicidal ideation than whites. And in India, men are less likely to report suicidal ideation than women. Another example is that African American and Latino youth may be more likely than their white counterparts to express suicidality via aggression, risk-taking behavior, anger, or irritability. In India, clinicians may consider minority status based on education and income levels, religion, caste, or other identities that may be marginalized. Cultural sanctions are defined as messages of approval or disapproval regarding suicide that individuals receive from their culture. Further, Chu notes that among cultures where interdependence is salient in defining self and self-other relationships, cultural sanctions about suicide can determine whether certain life events or experiences are seen as shameful. For instance, in some Asian cultures, suicide may be considered an acceptable response to bringing shame upon oneself or one's family. Specifically in India, individuals suffering from terminal illnesses, farmers who have suffered losses, or young adults who have experienced failed romantic relationships are more vulnerable to suicide. Further, with clients from India, it may be useful to assess culturally rooted beliefs that clients hold toward taking their own life. For example, if a client believes he or she has been born in sin from a past life, this may increase their suicidal intent. Thus, in addition to assessing current suicidal ideation and resolved plans and preparations, clinicians should also attempt to assess specific cultural factors that may influence suicide risk, like level of social support, recent losses, and beliefs about the acceptability of suicide. Finally, let's review some appropriate short-term intervention strategies. Once a client has been assessed, it follows that an intervention be developed. In this video, I will review safety planning, which is a well-supported, brief intervention for the short-term management of suicidality among clients at low to moderate risk for suicide. Management for individuals at higher levels of risk may include inpatient care or constant supervision. I will review safety planning as discussed by Stanley and Brown. The intent of the safety plan is to help individuals lower their imminent risk for suicidal behavior by consulting a predetermined set of coping strategies. There are 5 basic steps of the intervention, and these steps should be engaged in sequentially until the suicidal crisis is averted. The first step is to help the client recognize signs that indicate a suicidal crisis is impending. These warning signs could include personal situations, thoughts, images, thinking styles, moods, or behaviors. The second step is to ask patients to identify what they can do without the assistance of another person should they become suicidal. Examples of these strategies include taking a shower, going for a jog or walk, doing a puzzle, partaking in a hobby, listening to feel-good music, or watching a feel-good TV program, or playing with a pet. Typically, activities are more helpful if they require attention, are soothing, involve physical activity, foster belongingness, and/or have worked in the past. Third, if the previous steps have been unsuccessful in reducing the crisis, then clients are to reach out to others and let them know that they are in crisis and need support and assistance in coping. Given this, Stanley and Brown recommend that if possible, the client should share the safety plan with the individuals named in this step. Fourth, the clinician and client work together to create a list of professionals or other services that could be helpful to the client when he or she is in distress. This list could include the client's current mental health professional or contact information for local 24-hour emergency treatment facilities in the area. Finally, even if no specific plan is identified by patients, a key component of the safety plan is eliminating or limiting access to potential lethal means in the environment. This may include safely storing and dispensing of medication, implementing firearm safety procedures, or restricting access to knives or other lethal means. The clinician should then review the entire plan with the client in order to assess the client's feelings about the plan and his or her willingness to use it. Once the client has agreed to use the plan, the client should be given a copy of the plan, and there should be a discussion of where the plan will be kept and how the client will access it. Finally, it is worth noting that the once popular no suicide contracts, which refer to clients' written commitment to maintain their safety to not make a suicide attempt, are no longer considered an appropriate intervention for suicidal clients, as there is no empirical evidence supporting their use. To summarize, one of the most serious mental health issues that clinicians face in their work is dealing with individuals who are expressing suicidal intent. It is the clinician's responsibility to complete a thorough assessment of the risk factors expressed by each client as they describe their thoughts, emotions, and behaviors. As the clinician collects this information, he or she is faced with the daunting task of determining the client's risk for suicide. A thorough assessment that leads to a well-conceived intervention plan is the ultimate goal for both client and therapist. Of course, the clinician must also provide adequate documentation that a thoughtful and professional process has been followed in completing the assessment and intervention plan.